Thank you for this opportunity. These are my disclosures. I would like to share with you how to use different closure devices, which one to pick, and how to work as a team managing post-polypectomy perforations. A number of closure devices are currently available. These include clips and suturing devices that can be deployed through the scope or over the scope. Among these different devices, through the scope clips are preferred because they can be deployed immediately after noticing a perforation, and they can successfully close post-polypectomy perforations because they tend to be small. Regarding the variety of clips that are available in the market, I urge you to scope out the exhibit hall and learn from the exhibits. When it comes to the technician who plays a major role in the outcome of any procedure, we would like them to be trained, competent, and ready to assist us. In order to have accomplished technicians, fully trained and ready to work, we have developed an endoscopy technician training program that is currently available, and having formal training will make these technicians help us much better. One key role that the technician should perform is to make sure that clips are available in the room so that if a perforation were to happen, they can assist with the device without the need to run out of the room to find a clip. That is critical. In terms of clip operation, there are 3 important steps. And if you're working with somebody that you have not worked with in the past, it is a good idea to practice these steps. Step 1, open the clip. Step 2, close the clip and close it slowly so that it helps the endoscopist to make some minor adjustments for effective deep clip application. And finally, deploy the clip only on command. You don't want an assistant to close and deploy the clip, and if you're not happy with that clip application, you have lost that valuable real estate. And finally, after the clip has been deployed, you want to confirm that the clip has in fact disengaged before the assistant can remove the device. Otherwise, you can tear that closure. So these 3 important steps are vital. And when it comes to the endoscopist, what is endoscopist's role? If you see a defect and you go and try to close the defect, you may end up with superficial clip application. What I mean by that is gap in between the 2 blades of the clip, as you can see. These clips are likely to be not successful in securing a leak-proof closure, and they are likely to fall off within the first few days and letting a leak develop in the first few days and peritonitis. Instead, we should aim for deep clipping. How do you go about doing this? You should understand that every clip in the market retracts on closure. Unless you compensate for that retraction by either gently pushing the clip or pushing the scope forwards as you close the defect, you're not going to get deep clipping. By gently pushing and closing the clip, you will achieve deep clip application with no gap in between the clip blades. That is secure closure. You should aim for edge-to-edge complete closure. After closure, take time to take photographs from the cecal side as well as anal side to document secure closure. This is critical for the surgeon following with you so that he doesn't push you to send the patient for emergency surgery. There are some pitfalls with the clips, especially when you apply the clip superficially and not deep clip application. It may interfere with laparoscopic closure if the primary closure was not successful. It may interfere with the planning of surgery, especially with continued leakage and peritonitis, in which case the surgeon may elect to do a diversion procedure with a colostomy instead of primary repair. Hence, it is important to apply the clips deeply without any space in between the two blades of the clips. With the advances in clip application, nowadays you can reassure your patient that if a perforation were to happen, these can be managed without surgery. What is the data and where is the data? About 20 years ago, we have shown that clip closure heals perforations. Even large perforations you can close, creating a leak-proof sealing. And for circular perforations, it is best to close in a longitudinal fashion instead of a transverse fashion that would allow you to create a leak-proof sealing. Finally, unlike surgery, where you don't interfere with the peritoneal, you don't need a peritoneal incision, clip closure, endoluminal closure, results in less adhesions than surgery. And we have a lot of literature to support that clips do help in managing perforations. It's also important to reassure your patient that we can manage perforations, but for the most part, perforations can be prevented by following safe principles of colonoscopy consisting of a clean colon, excellent tip control of your scope, and the routine use of carbon dioxide. When I do my procedures, when I'm planning to do a large resection, I make it a point to clear the fluid both proximal and distal to the site of resection so that I don't get into trouble with fluid flooding the area of resection, especially this difficult resection with peristaltic contraction. Another important point is before I resect, I want to ask if the lesion is dependent or not. If it is dependent, I do not cut. I change the position of the patient to make the lesion non-dependent so that if a perforation were to happen, I would not get into trouble with fluid escaping into the peritoneal cavity by keeping the lesion non-dependent. I routinely use a smaller snare, especially for cecal resections, 10 millimeter snare, so that I don't get into trouble with inadvertent muscle entrapment. When it comes to resection, you should keep in mind preserving the submucosa is important. When you preserve the submucosa, you are less likely to end up with perforation. And it's also important to keep your electrosurgery in front of you and hear for the beeps of electrical current delivery. The longer time it requires, you may end up with deep thermal injury that you may not notice. So when you end up giving more current, not a bad idea to close the defect to prevent delayed perforation. Principles of snare application. Important to keep your snare parallel to the wall to avoid muscle entrapment. And when you close the snare and you see a lot of movement underneath the snare, try to distend the colon, relax the snare, allow that deeper portions of the wall to fall back and then re-snare. After cutting, Make sure you check the resection base to assess the depth of resection. If the resection is limited to, if the resection leaves superficial submucosa intact and even deep submucosa intact, you don't have to worry about perforation risk. In those cases, there is no need to close the defect unless you want to prevent delayed bleeding, especially in the right colon. On the other hand, if there is a muscle injury, if there is a doubt of muscle injury, you may want to do submucosal chromoendoscopy to figure out. And if there is doubt of muscle injury, it is best to close the defect because muscle injury can precipitate delayed perforation. And regarding hospitalizations, you can decide based on the comorbid status of the patient. When perforation happens, you should ask if there was peritoneal contamination or not. If not, after closing the defect, you can decide about hospitalization, start broad spectrum antibiotics, CT abdomen and pelvis with contrast, and early surgery if the patient deteriorates during observation. On the other hand, with peritoneal contamination, obvious peritoneal contamination, surgery is the way to go. In summary, endoscopic closure can prevent perforation if there is muscle injury, can manage perforation without peritoneal contamination. Surgery is required if there is obvious peritoneal contamination during endoscopy or if there are clinical signs of peritoneal contamination during the observation period. To show you the techniques of closure, I have assembled here 41 videos on my YouTube channel under the playlist Closure of Defects and Perforations for the trainees to learn how to apply clips and secure the closure. Hope this is helpful. Thank you.